like to welcome and thank Bill Henning from Mark Drug Medical Supply. They are a sponsor for us today, and we appreciate it very much, Bill. And why don't you tell us a little bit about your company, and then you can introduce our next speaker.
Thank you very much, Carol.
Sure,
I'm Bill Henning with Mark Drug Medical Supply. We're a full-service retail DME company. We do anything from Medicare, Medicaid, private insurances. Our store, we have anything from lift chairs, walkers, you name it, from DME side, active daily living, as well as beds, walkers, rollators, anything that we can stuff into the store is ready here for you guys to come by and see. So welcome to Mark Drug Medical Supply. We're at 548A West Dundee Road in Wheeling. And we are open right now during the pandemic between 9 and 5 p.m. Monday through Friday, and 9 to 4 on Saturdays. Thank you very much, and thank you for the opportunity to announce Erin Vogt she is a clinical care coordinator at Dutton, Casey, and Mesoloras. She is an active member of numerous local aging coalitions and professional aging and disability-related organizations. Before working at Dutton, Casey, and Mesoloras, Erin served as a manager of a community and service resource center for a hospital network and coordinated a variety of related programs. She has also served as an elder abuse investigator and long-term care ambulance. I screw that up all the time. So let's welcome Erin, and you guys have a great afternoon.
Thank you. Hi, everyone. My name is Erin Vogt, and I'm with Dutton, Casey, and Mesoloras. But today I'm here to talk about elder care resources. And my love is older adults. And before I get started, I want to show a picture of my grandparents. I'm hoping you can all see this. Those are the people that inspired me, and I hope I don't start crying, to become an advocate for older adults. Although when I was a child, they were probably in their 40s, so they weren't technically an older adult, but I always saw them as older adults. And now that I'm 51, I'm an older adult myself. Emily, thank you for moving my slides. I'm a fantastic social worker and care manager, and I'm an advocate, strongly opinionated advocate for my clients, but I'm not very good technologically gifted at all. Those are my kids. So those of you who have talked with me before, I welcome any questions. I want this program to be more of a conversation as opposed to a lecture. We've been having fantastic programs all day. I cannot sing, that's another skill I don't have, or play an instrument. My mom, Pat Houlihan, is on this, and she can attest. I did try playing the violin as a younger person, and it did not work out so well. So we have to just, in our mind, go back to those playlists that Melissa talked about having us put up for ourselves as well as our care receivers. And also I loved the music that Silverado had on their commercials. So just keep having that play through your mind. I'm going to hopefully that this is going to be very interesting. I've got quite a few professional colleagues on this webinar as well, and I welcome you. I will prompt you to display your information as well and answer questions. So again, I do not want this to be a lecture. Please feel free at any time to ask a question. You can put it in the chat, or you can unmute yourself if that's a possibility. Emily, is that a possibility that people unmute?
I can watch the chat, Erin. Not
okay. All right, thanks. So move my slide, please. Again. So today we're talking about family caregivers. And these are individuals that really, as you know, you may be one of them, you may serve them. These are the individuals who stand behind the person receiving care, and oftentimes, if they were not there, the whole ball of wax would just fall over. So I have been an advocate of serving family caregivers since the mid-90s, when it wasn't all that common to do so. and I'll date myself a little bit. When I got my social work degree back in '98, there was no track for working with older adults. I made my own track. Fortunately, things are changing and there are more people interested in working with older adults, but it's certainly still an area that we need to continue to keep serving. On this slide, this is nothing that none of us don't already know. We're healthy on the top and function continues and it goes down. We could be at home. We could have limited abilities. We could have and cost. So the first line is my parents, who are doing extremely well. We've got some supports in for dad who has cardiac issues. He's still working. So he's the first one. And I'm going to use my parents because that's my frame of reference. So my parents, they're still doing very well. They're in their own home. Dad has some limited functional issues, cardiac pretty much, bad knees, although he deserves it after everything that he's gone through in his life. But they're still doing relatively well. Regarding where they're at, they're still in their home. We are paying for some more care. But as things progress, look at the slide. So we get limited function, things go down. The people can stay in their own home. I have clients who will live in their own home, will bring in resources. We can bring in so many resources. And one of the things that I particularly love is being a resource and a resource advocate. So even if you don't use our law firm, you can feel free to contact me for resources as well. And Emily or Carol, could you put my email address and phone number in the chat so people can feel free to reach out to me?
Certainly.
So we obviously have, in our service area, in the Chicagoland area, we have so many resources, but they are oftentimes very dependent on money. As Dr. Forrest mentioned in the previous presentation, unfortunately, it's a big business. Oh, excuse me, the phone is ringing, sorry. My office closed at 3 because it's a blizzard apparently downtown, and now they're calling me from the office when I don't know for what, but here we go. So we can bring in resources into the home. There's thousands of resources we can bring into the home. We can look at someone going out partial day. I'm talking before COVID. We can have loved ones moving to a variety of senior housing options. On that chart, as you'll notice, the cost keeps going up. The bottom part is really where I focus. My role with the law firm is to help our clients figure out all the other pieces to their life. The attorneys do their documents, and I help with everything else with my trusted partners, one of them being ElderWorks. So there's just so many resources that people just don't even know exist. For instance, that band that Dr. Forrest talked about with the GPS, that's something that I knew because I'm in this field and I live it every day, but many people who have a loved one with a dementia may not even have known. You don't know what you don't know. So that's why we want to all be working together to serve everyone that needs to be served. Can you move on to the next slide, please? Again, this is just another representation of that continuum. My parents at one end and going down. Hopefully they're not going to go down too well or too much because I do this on a daily basis for everyone that I work with. When it becomes my parents, I'm back to being just a mush. So all my professional resources, Carol and Gail are on this call. Joy Schultz-Killian, who is a care manager I trust immensely. Those are all individuals who I have talked to when I'm working on behalf of my parents and myself as well. So just another representation. Next, I'm going to go past this really quickly about hospitals, but I want people, just today even, people, I had a client who thought that they could just stay in the hospital until their loved one was better. And discharge planning starts immediately upon admission to the hospital, and sometimes we're not even admitted to the hospital. So there's a lot of people who are still being put on observation stays, and they may not even realize that they're on an observation stay. The room looks the same, the hospital looks the same. They may be receiving services that are inpatient related, because you're in the hospital, you're thinking that you're an inpatient, but technically you're an outpatient and are being served in that capacity. And that really impacts billing and insurance. Right now with COVID, there's the three midnight stay is starting to be a little bit relaxed. I've seen that a lot, especially for someone who has COVID. In the past, before COVID, you had to be in the hospital for 3 midnights as an inpatient in order to qualify for care in a skilled nursing facility for rehab. Those 3 midnights right now are being waived, and we're seeing a lot of relaxation because of this whole pandemic. But it is still important to realize that as soon as you're admitted or as soon as you're in the hospital, find out, are you an inpatient or is my loved one an outpatient? Because that really does impact your insurance on many different levels. So go on to the next slide. Oh, let me just mention one thing. Sorry, go back one. It talks about private rooms. Well, nowadays, most hospitals have private rooms, so those are insurance is picking those up. In years past, people had, double rooms. And if you had a private room, then that wasn't being picked up. But I'm seeing that more and more that that's our only option. People don't want to have a roommate. And I don't want a roommate when I'm in the hospital. So we're seeing more and more hospitals catering to people's really intrinsic needs and privacy issues. So that's one thing I wanted to mention on there. Next, please. Discharge planning. My clients, as soon as I work with a family that is even on the way to the hospital, I want to find out who their discharge planner is. Maybe they're not going to know that right away because they're still in the ER, but that is a key person. You want your doctors and your nurses and your respiratory therapists, but you also need that discharge planner. They may answer to different terms, case manager, social worker, discharge planner. But if you ask at the nurse's station who your care manager is or discharge planner, you'll get to the right person. And that's a person that really I want to know right away so that they're able to help, because remember, you're not going to live in the hospital. You got to move on. So they're going to help to put that plan together. And again, just this morning, I had a family thinking that their loved one was going to stay there until his cardiac issue kind of resolved itself. And that was definitely not going to happen. So just reminding yourselves that discharge planning starts immediately upon entrance into the hospital. And the terms that when you're looking at Medicare, and I'm going to give you a couple of really good resources on the next slide, but when you're looking at discharge planning, the basics are evaluation, discussion, planning, determining if that person is going to have a caregiver, do they need support? A very good friend of mine, her husband recently had part of his lung removed and he went to a rehab hospital. She didn't know how to transfer him off the bed to the commode. So again, part of this was training. We worked with the care manager right away. I knew he was going to be there 2.5 weeks, but I am not going to wait till 2.5 weeks or 2 weeks to get her started to be trained. So we've got a plan. Referrals to agencies and arranging follow-up tests. Those are things that can be very time consuming. I'm working right now with my daughter having some blood issues and really trying to deal with the medical world. As a person in the trench again, I'm like, oh my gosh, this really takes a lot of time and a lot of perseverance. So again, Dr. Forrest talked about the buddy system. Let us, all of us that have been here today, help you. There are so many resources, but it's very, very fragmented. And again, discharge planning starts at admission. Or if you're in the emergency room and you're not going to be admitted, it starts right then. How are you going to get back home and what resources need to be put into place to start helping you then? The next slide, please. Carol, are there any questions on chat?
Not so far.
All righty. Here's some very good resources. And I can supply these to Emily and Carol and Gail from ElderWorks if you want me to supply these, so you don't have to write these down. I'm a resource queen, so I want to provide as much as I can. The National Family Caregivers Association has a fantastic booklet. Now I realize we don't all have time to read these things, but it's a really succinct booklet about what to do when your loved one's hospitalized. Again, pre-thinking. The pack and go bag that Dr. Forrest talked about, fantastic. Have that ready, but have one ready for yourself as well. Hospital discharge planning, another resource that's great. Hospitalizations for people who have dementia, it's not good when they're in the hospital. This is a very, very good resource. Hospital Happens, a guide for hospital visits for persons with memory loss. And the Center for Medicare Advocacy. This is a fantastic organization that not all of us know about. And sign up for their weekly email blasts. They have a lot of resource information on just topics that, until you're in the midst of the crisis, in the midst of trying to figure out what the heck is going on, are they an inpatient? Are they not an inpatient? They're an outpatient. What's the settlement? All these different terms. They have fact sheets that are written for you and I, not for a physician level or an attorney level, but they're taking out some of that legalese, and it's written for us. Good talking points. I love this Medicare advocacy group. Okay, Carol says it'll be on our website. All right. I don't have my glasses on, so that print is really tiny, but I'm trying. So those are really good resources. After a hospital stay, my client today thought they were going to stay in their local community hospital. No, they're not going to stay there. They're going to go to what we refer to as an LTAC, which is a long-term care acute hospital. There about 5 or 6 in our Chicagoland area, and these look like traditional hospitals, but they're geared to take care for people who have an acute medical condition but a longer stay, because you're not going to stay for a month in the local hospital. So I want to make sure that people are aware of some of these other resources. They're called LTACs, that's our lingo, long-term care acute hospital. And Medicare.gov, which is another really easy to use website, has really good resources.
Erin, maybe you could give an example of that long-term care acute hospital, because, you know, I had that friend of mine that had pancreatic cancer and then ended up in Marion Joy, and I thought she was in rehab, and you're the one that informed me, no, she really wasn't. She was in the long-term care acute.
Yes. So when you're in a community-based hospital for whatever's going on with you medically, and you need to go to the next level of care, sometimes you go to acute rehab, which I'll mention on my next slide, or you're going to go to a long-term care acute hospital, which is the LTACs, or you're going to go to a subacute rehab, which is what some of us may think of as a nursing home. But the long-term care hospitals, AMITA has one in Des Plaines, RML, Kindred. There's maybe 4 or 5 different organizations that run them in our service area. They're billed just like they would be billed as an inpatient hospital. You wouldn't be an outpatient, like I mentioned before. Are you inpatient or outpatient? For an acute hospital, you would be an inpatient in an LTAC. And they're typically stays for at least 30 days. My client today is going to AMITA in Des Plaines. They have too many medical needs to go to a subacute or to an acute rehab hospital, but they're not going to stay in the community hospital getting all their treatments. They're moving on to the next level. Does that answer that question, Carol?
Yes, I think it does, because
Okay.
they had gone to rehab. She was at Marion Joy, and I said, but she's not getting a lot of rehab. And you said, no, that's because she's at the long-term care acute hospital. So,
and some hospitals have they're licensed for different levels of service. So you could be in the same hospital, but you're in an LTAC bed or a rehab bed. Go on to that next slide just for a second. Okay, so the acute rehab hospitals, this would be, so just for an example, my friend who had half his lung removed. So he was in his community hospital, he had the surgery, and he was recovering fairly well. Then he developed pneumonia in the other lung, and it was just this back and forth. And the hospital said, well, he was ready to go to a subacute rehab. And I said, I didn't think so. And we had a discussion about this, and I brought in some providers, and I'm going to talk about a care manager and what we do in a few slides. But I put on my care manager hat just for my family friend, And we had a discussion, and my client, or excuse me, my family friend ended up going not to a subacute rehab. He went to the rehab hospital because he really needed still some monitoring with the lung, but he was able to get about 3 hours a day of physical therapy and his therapies. And if he had gone to a skilled nursing facility, or what we refer to as nursing homes or subacute, it would have been about an hour and a half a day. And I was concerned for him because he still had a drain thing coming out, that wouldn't have been as monitored as if he wasn't with a higher level of acuity. So he went to a rehab hospital, and those are also built just like hospitals. Amita has one in Elk Grove Village. Shirley Ryan is obviously a huge one, and they have many different organizations in the suburbs. Marion Joy in Wheaton is an acute care hospital. They have, some of them have dual licenses, but they're traditionally rehab hospitals. You're not going to live there again. Traditional stay maybe 2 to 2.5 weeks, but you're getting a more intensive level of therapy, usually about 3 hours a day. Are there questions?
No.
Nope. All right. Okay. Next slide. Oh, one thing I wanted to mention. With the acute rehab hospitals, you know, Medicare controls so much our insurance companies. I won't start on that political rant that I have. But many people want to go to an acute rehab hospital after they've had a hip or a knee replaced or surgery. And Medicare only allows about 25% of individuals with those two procedures to go to a rehab hospital. They're having more people go to subacutes. That's just a little tidbit for you. Skilled nursing facilities, we refer to these, or we may know about these as nursing homes or subacute rehab. And these are, Manor Cares, Lexingtons, Aldens. Many of the nursing home providers are really looking at not having the quote traditional older person who lives there for the rest of their life. They're really looking at people who can be rehabbed and go home, or rehab and go to somewhere like assisted living or another level of care. But these are places also, you're not going to necessarily live there. Medicare, there's so much misnomer about what Medicare pays for. And just a tidbit, we're going to be having a program on Medicare and what it pays for in March. So those of you who are interested, I will get that information out to you, because Medicare does not pay for a whole lot of things, especially when it's dealing with long-term care. And so much of our conversation today has been dealing with dementia. And so much of what an individual with dementia needs is supportive services. It's not skilled nursing care. And that's what Medicare pays for, skilled care. You need a licensed professional to provide it. You had a hip replaced, you need a physical therapist who has a license. I don't mean to be gross, but you've got a draining wound, you need a nurse to deal with that. But so much of our long-term care that our loved ones need is not something that Medicare is going to pay for. It's a complete misnomer that Medicare pays for everything. It's daily I'm dealing with, I thought that would be paid for. No, it's not. And in a skilled nursing facility, the most you're going to get is 100 days, and it's really being capped a lot sooner nowadays. Again, COVID is putting some additional protections in this realm, because people don't recover from COVID within 3 months necessarily. So that's a little bit less. But just in generalities, people just need to realize that Medicare does not pay for it. Medicare doesn't pay for a caregiver to come to your home. If you have a skilled nursing need for a certain amount of time, it'll pay for a nurse to come, but it's very incremental. But again, most of us who have a long-term care need with support being needed, that's not a medical service that Medicare pays for.
And so the question on that too, Erin.
Oh, okay, sorry.
Sorry, I didn't mean to interrupt you.
No.
Said, and this was from one of my colleagues who said, we get many people that think they have 100 Medicare days, exactly what you're talking about. and then find out the loved one's is discharged long before that.
Correct.
The reason, or why does that happen?
And one of the reasons is, if you look on the slide on skilled nursing facilities, go to the resources, and it's the search Jimbo, I can't even say that, settlement. That is a settlement that was done about 5 years ago. In the Medicare regs, there has never been that you have to improve. And all of us in this field, a majority of us, have that, okay, they're not improving, Medicare is going to stop paying. And it's actually not the case, but that is what's used continually, that the service is going to stop because you're not improving. Mom's not going to be able to walk 90 feet. We can get her to walk 35 feet. Or someone who has MS, maybe they need rehab, but they're not going to get back to where they were in their functioning level, but it's going to maintain them. So if you look on MedicareAdvocacy.org, remember I love that website, and search Jimmo versus Sibilis statement. Those are the very, very good talking points about Medicare. And I've been able to, not always, I'll be honest with you, not always do I win. But sometimes just educating and look, hey, look at this. This is actually the reg. You don't have to improve. That may, if you get up to the higher enough person, I don't always win, but that's a good resource for you.
We have another question. Can a patient live the rest of their life in memory care unit of a skilled nursing facility, Medicaid pending?
If Medicaid is going to pick it up, Medicaid is the #1 payer for long-term care, because how many of us have $10,000 a month that we can pay? In my whole time of being in this field, which is now quite a while, I have only met 2 people whose monthly income is higher than their cost of care. So unless you have this huge money bucket somewhere, or you have a tree that you can pluck the money off of, and I'd like a branch of that, many of us are looking at Medicaid, and people don't necessarily even think that you would ever consider that. But if your cost of care is far more than what your income is per month, and that nest egg is going to keep going on and down. Medicaid, if someone is in a nursing home and they're in a Medicaid bed, and this could be a whole talk, and I can help you afterwards, or Carol or Gail, or any of the gals from ElderWorks. If they're in a Medicaid bed, which many nursing homes have distinct parts, which are not every bed is licensed for Medicaid, not every bed is licensed for Medicare. If they're in a Medicaid bed and Medicaid is going to pick it up, they could stay there supposedly for the rest of their life. Well, if they're in a Medicaid.
Let me jump in here, Erin, because
yes,
I do know who asked this question. And the question is, could they live their life in a memory care unit of skilled nursing on Medicaid? First of all, you don't get into Medicaid until you've done a spend down. So if they have resources, which there were, I believe in this case, that would have to be spent down first. And secondly, if you're in nursing home care, there's very few that have a memory care unit. We have a variety of community people there that need many types of care. So it's not a memory care unit like if we were to go into memory care. So I think that's what they're asking here is, could they live in skilled care on Medicaid in the memory care unit?
And I appreciate what you said, Carol. And also, when you have an individual who is later stages in dementia, many times the memory care units are people that they're secure units, and they're for people who have an elopement risk. They're still able to walk, and you need to protect them basically from themselves. As the dementia increases, many times people don't have that ability to wander or to walk as well. And then you're not even looking at necessarily a memory care unit. Programming is a little different. but I will defer to Carol and Gail and the ElderWorks gals regarding that question. I will let you know that Medicaid is a huge process and one that elder attorneys work with, and we'll get to that slide. I hope I answered that question. I wanted to give one other resource about hospitalization. The Parkinson's Foundation for people who have Parkinson's has a wonderful kit. You go on the website for Parkinson's Foundation and it's a hospital kit. And because their medicines with Parkinson's have to be timed so precisely that there's some talking points for your medical providers. It's just an absolutely wonderful kit on the Parkinson's Foundation website for people who have Parkinson's. Okay, so care options at home. We talked a little bit about this, and Carol, jump in, and anyone jump in about this. You have to be homebound to have Medicare have Medicare pay for your care in the house, which is only intermittent, and it's like 45 minutes, 15 minutes. It's just little bits and pieces. Maybe you'll have in-home therapy. Maybe you'll have a nurse that will come in and check a wound or something like that. But, excuse me, you have to be homebound. So what the definition of homebound, and I put it right here, is leaving the home requires a considerable and taxing effort, such as needing crutches, walker, wheelchair, or help from another person. Whether or not you qualify as homebound is decided by your doctor's evaluation. Now, don't worry about COVID because so many of us are doing telemedicine right now, but you still have to, you can't be going like to your grandchildren's soccer games and then be able to qualify for Medicare paying for someone to come into your home and check your wound. You have to be homebound. And that's another misnomer that many people have. Does anyone have any questions?
No,
Carol, do you have anything to add to that?
no, not at all.
Joyce, I know you're still on here. Do you have anything to add to that? Put it in the chat. Now, on the second line on there, I say leaving home for extended periods of time for special non-medical events. I have had people be able to go to a wedding and still be considered homebound, but it is a big hassle. So just generally thinking that people are homebound, that's how you get home health. And it's medical, paid for hopefully by your Medicare, but it's very short period of time. And you really can't work a care plan around that because, you know, the nurse may come in between 9 and 11. So you can't necessarily, you know, have that person by themselves for those 2 hours because that nurse may be coming in for 20 minutes. So it isn't something that you can have, you know, work a care plan as far as caregivers and more resources. And it's actually becoming much more restrictive for home health, and which is another whole topic that we can talk about for days. But just be aware that you have to be homebound and you have to have certain medical conditions. Someone who has a dementia, who needs supervision, that's not a Medicare paid for service. So there's all these qualifying events. I'm seeing some things pop up on chat. Is there anything I need to address?
No, we're just, there was a comment between the ElderWorks groups, and we just wanted to clear up something between us on the supportive living licenses. So.
Oh, all righty. Okay.
Sure.
And the other thing with home health, years ago, you used to get a social worker when you had home health ordered by your physician. Not anymore. That has to be specifically requested, and it's very narrow window of services. So that is not a guarantee anymore that you get a social worker. Another reason that we need ElderWorks. I'm going to go on to home health, from home health. Other resources in the home. Can you move it to the next slide? There's some really good resources again on Medicare.gov about what Medicare pays for home health, and also using that Jimbo's, I can't say that, settlement. If you're having physical therapy come into the home and the provider says we have to stop because you're not making progress, using again those talking points for that settlement may be very helpful to keep that service level going.
Now, we do have a question here. Does home health change if family caregivers live in the home?
Home health, Medicare paid for home health should not be a qualifying event. There may be some instances, and I deal with a lot of abuse and neglect. There may be some instances where the home health agency says it's not a safe situation and they're not going to come in, so that we have to have more caregivers in the home. But for Medicare to pay, it should not be qualified if there's someone else in the home to pay for it. It's a medical necessity. There's a medical need for that. Again, there's quite a few hoops you have to jump through for home health, and it's not a long-time service level. It's not a long-time service.
Okay, thank you.
Mm-hmm. Next slide, please. Okay, so here, the majority of people who are living at home, the caregivers who are coming into the home are private pay. There are some services through the community care program for people over 60 and the Department of Rehab Services for people under 60 who have a physical disability. And then if someone has an intellectual or developmental disability who is on this call, let's talk offline because there's some additional services we can tap for you. But just generally speaking, it's private pay. So there was a lovely commercial, I can't remember which agency it was. I am overprotective of what agencies are involved with my clients. Was it Comfort Keepers, Carol? Who was that agency that had their lovely commercial on this today?
Comfort Keepers have
okay.
For this.
Comfort Keepers is an organization I trust. There are so many now. I think there's about 500 in our service area. And I do not want the people who are serving my clients to learn about aging from a book or a binder. Now, we can't all have life experience, but if you worked at Kohl's last week and now you're bought a franchise, I don't necessarily think that you're the best fit for my client. So I am completely overprotective. Some resources, Guide to Hiring in-Home Help, which I wrote, I can send you. It's also on our website. There's an organization for non-medical in-home help agencies. That's a website, and not all organizations will qualify to be part of that group. So that's one level of screening that you can look at. And then, of course, my trusted provider, and yours too, is ElderWorks. I have their phone numbers memorized. I'm calling all the time. Because there is so much out there that how do you know, how do you evaluate? Having a trusted provider like ElderWorks to help us, I'm calling them all the time. And one other resource that I wanted to mention, and Dr. Forrest mentioned it about home safety, the National Institute on Aging, their website is really, really good. And they have a whole booklet, not that you want to walk around the house with the booklet, but it has things that you may not have even thought about, like the Tide Pods, just watching the cords, making sure that your house is safe. And they have a really good booklet on home safety. Just that to mention that.
We do have another comment in here.
Okay.
Please mention the Veterans Independence Program through the VA.
Okay. Someone mentioned that. Carol, you talk about it.
In Illinois. Great funding available for veterans. So there are several different programs for the veterans, and there's a specific program that is available for home care or for any type of care. And your benefit is generally greater if you go into a community and you need care there versus staying at home and getting care. There's specifics on it. We can always give you information and a contact. And then they also mentioned Age Guide Northeastern Illinois, which also has,
That's an area agency on aging, and I will get to them as I get to my more resources. What time is it? I don't even have any idea where I am at.
it's 25 after, and we
Okay.
are here until 1:45. I'll give you a 5-minute.
Okay, because I could go on for days with this.
Okay.
There is so much equipment. I'm going to go to the next slide. Mark Drugs, which has been playing on your commercials today, but even regarding that, they are my #1 trusted resource for all things DME. There is so many doodads to help people that I don't even know. I don't even know what I don't know. So sometimes I will call and I'll be like, okay, I need this to be able to do, I need a client and they have to have help with whatever it is. And they'll be like, oh yeah, there's this resource for that. So knowing who your trusted providers are. Now, Medicare will pay for some medical care, medical equipment. For instance, a wheelchair. It doesn't pay for those fancy wheelchairs that we see, you know, when it's not COVID season or snow outside. It pays for the basic wheelchair like you see on this picture. It used to help pay for some of the motors in those raised recliner chairs, which are fantastic. And that same client or family friend I was talking about with his lung, when he was ready to discharge, I said, we need to get him one of those chairs. And I called Mark Drugs and it came the next day. So I didn't have to, you just need to know who your providers are and who you can trust. Because those chairs that just help, it doesn't like fling them out of the chair, but it just helps enough if you're a little bit weak to get you standing and then getting going. So there's so many different products that are available. Medicare has become much more restrictive as to what it will pay for. So Medicare.gov has a really good booklet on what it would pay for. It does sometimes, a majority of time, pay for hospital beds. Can be a little bit restrictive on how to get that Medicare coverage if you're not in a hospital, in a hospice program, but it's doable. Sometimes people, this morning, I put in the comment why someone doesn't get out of bed. Well, sometimes they just can't get their body going to get out of bed. Excuse me, the office is still calling. They can't get their body going to get them out of bed. So maybe a hospital bed, which is a little bit higher and has bars and a trapeze bar, just giving them something to grab onto could be really, really helpful for them. So there's all kinds of equipment. Maybe a bar that goes underneath the mattress that gives you like a side grabber, you know, just to pull yourself up. So there's lots of equipment. Some of it's private pay. Some of it you can also get at medical, you know, what are they called? Loan closets. Before COVID, again, many, you know, community-based senior centers, healthcare organizations have a lending closet. So if you're wanting to try something out, I know Mark Drugs with my friend with the recliner chair, we weren't sure exactly like which model he needed. So they let us try one for 2 weeks until we figured out what he needed. So, you know, look at those resources. There's just so much available. There are lots and lots of resources, and just knowing who you can trust. One other resource, which I wanted to mention about doodads and equipment, is the Illinois Assistive Technology Program, or ILTEC.org. This is another group that I will call when I don't have any idea what the term is, what I need it to do. And they'll be able to help me figure out what my term is, and then I can get them the product. Because there's so many. I mean, I've got clients who have ALS and we need to get them, you know, readers, and then I've got clients who just need a grip on their pen. I mean, there's just so many resources, and that's the Illinois Assistive Technology Project. And I'm all about using community-based resources when we can. Because everything, you know, so much is private pay. So when we can use community resources that are funded by organizations or grants, they also have access to a lot of grants. I'm not going to go through the definitions of senior housing. We have the experts on this webinar or that are facilitating this webinar. I work with ElderWorks almost, I think probably on a daily basis for something. And they are the experts in housing. all things housing. I don't even need to clutter my mind space. I just call them or email them because there's just so many options. There's so many variables. There's so many different contracts. These are the people who we can all trust and work with. So I'm just going to skip through this housing options.
Thank you, Erin. Also, Joyce Schultz-Killian, who is one of the care managers that we all work with, another care manager in addition to yourself, who's excellent, mentioned that the Senior Volunteer Network in Crystal Lake remains open and is currently still lending DME equipment.
Wonderful. Thank you. It takes a village to serve others, and we all need to work together. So thank you for that, Joyce.
Yeah, thanks,
Okay.
Joyce.
But the one thing that we don't need to worry about housing, just call ElderWorks. Okay, let's go on to professionals. Excuse me, I've lost my page here. Elder law attorneys. Lauren and Matt, they've had a commercial running, which I just thought was hysterical, that they are wearing matching clothes. I just thought that was great. They're human. Elder law attorneys are individuals who are approachable, I would like to think. You don't go to an orthopedic doctor when you have an eye issue. And this is an area when you're dealing with a loved one with needing powers of attorney or yourself, you want to go to a specialist. Elder law attorneys are the specialists in law. When you're dealing with someone who has a disability, I have children, I have clients who are too. So we're working with the families on how to help access programs for these children, all the way up to, I've got a client who's 110. So the elder law attorneys are the experts in the area of law. The difference that I've been with this firm now almost 11 years, they recruited me. I came from healthcare, and back in the 90s, I was an elder abuse investigator and a long-term care ombudsman, which is advocacy for people in nursing homes and assisted living. And this was one of the only firms that would help without trying to figure out how they're going to get paid and those kind of things. And there's no money to pay for resources, very, very little. And I worked with them, and they would speak my own language. And then I was recruited into a hospital network, which I won't mention the name. Those of you who know me know which one it is, and it's not a bad one. I was there for 14 years, and my position was eliminated. And subsequently, during that same period of time, Jana Dutton, who was the first elder law attorney in Illinois, called me and said, did I remember her? And I'm thinking, yes, you're like one of my icons. But anyway, and asked if I would come down and talk with them just about working with them, because the elder law attorneys are doing so much with the families that the attorneys are not experts in, because there's all the resources and all the advocacy, even just how to do a care plan in a nursing home and all these different things. And so I was brought in, and I've been there almost 11 years. My daughter was just 2, and now she just turned 14. So maybe it's longer than that. But anyway, I'm not good with math. You want to go to an attorney? Pardon?
That would be 12. 14 minus 2 is 12.
Okay, so then I've been there for 12 years. I don't even know. But when you're looking at an elder law attorney, you want to go to one that specializes in elder law. And the 2 associations that elder law attorneys belong to are NALA, which is the National Academy of Elder Law Attorneys. And then the other one is the National Elder Law Foundation. And the biggest issue that I find with elder law attorneys as opposed to traditional estate planning attorneys is estate planning tends to look at, they're going to do your powers of attorney, but they're not necessarily going to customize those to a disease state, which the powers of attorney can be incredibly customized based on an individual circumstance. So the elder law attorneys are looking at, yes, maybe how you're going to leave a legacy, but also how you're going to pay for all your care and making sure that your documents are in the correct order. And if you need Medicaid, how is that going to work? And, Medicaid has a 5-year look back. So you don't want to wait till the last minute. Again, just today, I had a couple call. The wife has been diagnosed with dementia. not sure what kind, but she's no longer decisional. And Dr. Forrest talked about how people, or maybe it was Susan this morning, sometimes aren't diagnosed until they're very long in the dementia process. And so this wife is no longer able to make decisions. She's not decisional. So we have to go to guardianship court. If a little bit of pre-planning in the previous months, maybe even years, we wouldn't have to go to guardianship court, which is a court proceeding, and it's, it's expensive, it can be messy. No one wants to do it if you can avoid it. But just a little bit of pre-planning. So making sure your powers of attorney are customized to your situation, making sure that your estate planning documents look at, my loved one has dementia or Parkinson's or MS or ALS, or I have a 2-year-old who has special needs, or whatever the situation may be. And what's happening, what I'm seeing now, Jana started the firm in 1989. So people who saw her in the early 90s or the 90s, and they were very healthy, now they're not so healthy. So they're calling back and coming in and making sure that documents are corrected and I'm helping them to get resources. So you want to just establish a relationship with an elder law attorney. And again, those two associations are NALA and NELIF. And both of those websites have locate an attorney on their website page. And the elder law world is fairly small. So we know, I know Mark, Matt and Lauren, and there's not that many of these attorneys, and we all kind of work together. Yes.
Sorry. So we have something here from one of our people that's on, one of our attendees, and said, I've just started the process, well, actually back in October of 2020 with DHS because my husband is 59 and we are scheduled for an interview or visit by phone next week. Is there anything that I should know about what we may be entitled to or that I should be sure to ask about? Let me say we have 10 minutes.
Okay. That's a long, very important question. Please email me or call me and I'll be glad to help you because yes, that is, and because he's 59, there may be some asset protections that could be done if he's not, there's some things when you turn 65 that you can't do when you're under 65. And I'll be glad to talk to you at my level about that. You probably are going to need an attorney, but I can certainly help you with that.
I'm putting contact in for them again.
Okay, thank you. Yes, that's a loaded question, but we can help. The other thing that I wanted to mention, and Dr. Forrest mentioned it also, was a POLST. That stands for Provider Order for Life-Sustaining Treatment. Years ago, actually up until about 3 years ago, it was just a DNR order or do not resuscitate. The POLST form has replaced the DNR because at the end of life, and when you're dealing with advanced care planning, the body can shut down well before the heart stops. And the DNR only dealt with the heart stopping, and you want CPR and the pounding of the chest and all that. It deals with ventilation and kidneys and a variety of other bodily functions, if you will. So it's called the Provider Order for Life-Sustaining Treatment. It is a medical order. It's not something that the attorneys will draw up. It's an order that the doctor signs or an advanced practice nurse or a third-year medical or fourth-year medical student. But it's something that when you're talking about putting documents into place, the 5 wishes is a fantastic document. We always give that to our clients in addition to the healthcare power of attorney because the standard form of healthcare power of attorney is very limited. The 5 wishes gives you many more options. And another booklet that I love is Hard Choices for Loving People. When you're dealing with talking about end of life kind of situations. And I want to mention palliative care and hospice in a minute. But the care managers. I am a care manager and I work with our clients. Care managers are individuals who they're traditionally nurses or social workers. And they are essentially your professional advocate. Joyce Schultz-Killian, who's on this call, is someone who I call probably not as much as ElderWorks, but often. And her organization, hers is called At Your Request Patient Advocate. I don't mean to plug her, but there are some people out there, again, I'm overprotective, as care managers who I don't trust. Again, I didn't want you working in another field last week, and now this week you're going to be working with my clients trying to manage their lives. That does not go well with me. So the organization that majority of the care managers that I refer to is called the Aging Life Care Association. And care managers can do a variety of things. They can go to doctors, they can, I mean, it's something from organizing, you know, making sure your house gets cleaned every 2 weeks, to being really, really involved on a daily basis. There's just so many things that care managers can help a family with. And if you have a loved one in another state and you're in Illinois and they're in Florida, you know, having a care manager in Florida, or oftentimes we have care managers in Illinois and the loved ones, the family members in Florida, and we have someone on the ground here. They're available 24 hours a day. So it's just a really fantastic resource just to be aware about. There are people that are putting out their shingles saying they're care managers because they help their loved one. And I'm not negating that, but again, I want some professional background, some certifications, and this organization, the Aging Life Care Association, again, has on their homepage, locate a care manager. Also, our resources with ElderWorks can refer us to proper people as well. But I want to make sure that you're aware of the care managers and what we can help with. You know, sometimes I become like an adopted dog. I'm personally adopted, so I just get adopted by another family as well. So, you know, it's being another person, another set of eyes and ears. It's another resource. People are in this field. They know the local resources. You know, it's very fragmented in our world, and care managers can really, really help. I want to talk just a minute about palliative care and hospice. Palliative care is, I think, I know it is, it's an underutilized resource. In our medical world, we have a doctor or an advanced practice nurse for like every body part, right? You have your eye doctor and your brain doctor, your neurologist and your ortho doctor and your skin doctor and this doctor and that doctor. But there isn't necessarily someone to quarterback that team. Palliative care serves in that kind of role. And my dad, I've got my dad on palliative care because he's got a cardiologist, two cardiologists, a pump cardiologist and an electrocardiologist, and his eye doctor and this doctor and all these doctors. And so I'm like, okay, we got to put you on palliative care. And it doesn't mean that he's going to die tomorrow. Palliative care has no like expectation that you're going to die soon, but it's just someone to help you kind of navigate what's all going out there. And really help quarterback that team. So I would say 90% of my clients are on palliative care because I just value this service so much. They're typically physicians and advanced practice nurses. They do home visits. It's a really underutilized resource. They bill your insurance, just like, you know, your eye doctor or your foot doctor bills insurance. But I really like this. Now, they're not going to be people that are going to come out in the middle of the night. It's not an emergent situation kind of care. It's not hospice, but it is, it's a consultative level of care, I would say that. Someone to help you quarterback what's going on with all the different providers. And my dad, in an example, his blood pressure was dropping. The nurse came out, she talked to the doctor, you know, like, let's figure all this out. Rather than me being a novice, or my dad who's not feeling well, or my mom trying to figure this out. You know, she was really, really instrumental. And I find that to be that very often for many, 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 many of my families. It is not hospice. It's oftentimes run with a hospice organization, but it is not hospice. Palliative care is its own service level. Hospice is a projected lifespan of 6 months of life or less. Palliative care, you have a life-limiting illness. My dad has a bad cardiac issue. That's a life-limiting illness. He's still working, he's still doing everything. But I want someone to help me and the family quarterback the team. And so this resource is fantastic. On the bottom, American Academy of Hospice and Palliative Care. And there's some organizations. And Transitions was one of the sponsors for today, which I really like. Some of the hospice and palliative care organizations have gotten so huge that my clients are now numbers, and that's not okay with me. I want Jim Houlihan, that's my dad. I want him to be known as Jim Houlihan, not patient 2312 or whatever it would be. So again, I'm just overprotective of people. Just realizing hospice is a fantastic service that many people sign into way too late in a disease process. It really helps families live until they die. It's a prognosis of about 6 months of life or less. I've had clients on hospice for 2 years because they're still declining, but they're not dead. And it may be because they're getting all these services from hospice. There's a nurse and a chaplain and a social worker, and they've got additional medical equipment to help provide care, maybe a special bed so they don't get wounds and all kinds of different services. It's just something that's so underutilized. And I just wanted to make sure that people are aware of that as well.
Erin,
Yeah.
we are at the end of our time.
I'm at my end. Okay.
5 minutes.
All right.
I think that we do
want to give one thing. Hold on.
Yes, go ahead.
The Veterans Administration has a National Family Care Support Program. So if you have someone who is in the VA, obviously ElderWorks knows everything. But I oftentimes am calling the Veterans Administration National Family Caregiver Support Program. They're all social workers, and they will help me navigate the VA because that is a huge system. And the phone number is right here.
And we will have a repeat of these presentations again on our YouTube channel as well as on our website.